Bill. Welcome, everyone. I'm Peter Kern, the Director of the Global Public Health Program, and I'd like to welcome you to what we think is the 7th annual Global Public Health Lecture Series. We've got a great power-packed lineup for you, and you can pick up a flyer for it. In fact, I'd also like to remind those of you who are students taking the class to sign in on the student sheet, and if you're a visitor, community member, please sign in on the community sheet before you leave tonight as well. So the Global Public Health Lecture Series is co-sponsored by the External Advisory Committee of the Global Public Health Program, along with the Institute for Health and Humanities, and with a grant from the Missoula Community Access TV. We're able to take videos of these presentations and put them on the Global Public Health website for you to look at or for you to share with others who couldn't make it here tonight. Tonight we have a really interesting lecture on the role of traditional medicine and ceremony in modern healthcare delivery to urban and reservation-based American Indian communities. And this lecture is going to be presented by DShane Barnett, Mandan and Akira. He's the Executive Director of the Missoula Urban Indian Health Center, and he's worked in the American Indian health field for more than 2 decades. He's the former Director of the National Council of Urban Indian Health in Washington, D.C. He has his Master's of Science degree in Healthcare Administration and Interprofessional Leadership from the University of California, Berkeley. And he has his Bachelor of Arts in Sociology with an option in Inequality and Social Justice from the University of Montana. Currently, DShane is a doctoral student in public health at the University of Montana, where his research focuses on the protective factor of American Indian ceremony, which you're going to be hearing about tonight. He's a member of the Board of Directors for the Montana Primary Care Association and a member of Providence, Montana Service Area Community Ministry Board. So please join me in welcoming DShane for tonight's.
Great, thank you very much. Quickly, it was actually UC San Francisco. I don't want to get called on the carpet for the wrong college, so no. UC San Francisco. So how Toshkani Toja. Good evening, everybody. My name is DShane Barnett. My mothers are Carlene Chase Lodeski and Kimberly Chase Dishman. My grandmothers are June Chase Nicholson, Diane Chase Hawk, Corinne Chase Dariana, Eleanor Chase Umlauf, Caroline Chase Pleats, and Francis Chase Black-tailed Deer. I'm a member of the Prairie Chicken Clan of the Mandan tribe of the Mandan Hidatsa-Rikra Nation of Fort Berthold, North Dakota. My grandmothers are children of the Sadi Lodge and Knife clans. As Peter mentioned, I have the honor of serving as the Executive Director of the Missoula Urban Indian Health Center, and I am also a PhD student here on campus, where I'm studying the protective factor of ceremony, specifically as it relates to substance abuse issues in adult American Indian populations. I took the time to introduce myself in the way that my mother's tribe and a lot of tribal nations throughout this country do, which is by identifying my family through my matrilineal lineage. And that's because in our system, this is a way of accountability and respect, so that you now know who my mothers are, who my grandmothers are. And when I say, you probably didn't escape notice that I said I had 2 mothers and 6 grandmothers. We're a clan system that's matrilineal. So our mother's sisters are our mothers, and our grandmother's sisters are our grandmothers. So I've grown up with 2 moms and 6 grandmas my whole life. And now that you know who they are, if I speak any falsehoods or mistruths here, you can tell them, and believe me, they will make sure it does not happen again. And so that's just a traditional way that we have of introducing ourselves. Normally I would have said it all in Mandan, but I don't think that would have gone very far. So I gave their English names. But I'm happy to be here tonight and dive into this question about the role of ceremony and traditional medicine in today's healthcare system. The question that we're going to explore today is, what role do ceremony and traditional medicine play in a contemporary healthcare delivery system, with a focus especially on urban and reservation-based American Indian communities? But why is this question even important for us to explore in a public health lecture series? After all, we live in the United States, a nation where separation of church and state is the law of the land. And here we're asking a question and examining something which is undoubtedly spiritual in nature. So when we're talking about ceremony, we're talking about traditional medicine, we can't separate the spirituality from the practice. And so I am going to argue that my years of experience, as well as a lot of research that has been published and that's coming out, is going to show that this absolutely is a public health and a policy issue, because what we see and what we know and what evidence is showing more and more support for every day is the fact that when healthcare services are culturally tailored and culturally appropriate, they are more effective and they are more cost efficient. So this is a public health issue, this is a policy issue, and it's something that in my career, I was able to literally see this play out in front of me. So as an Indian health administrator, so I've been working in the Indian health field for 25 years. This is actually my 25th year. And as an Indian health administrator, something that has always bothered me is that if a patient comes and my provider gives them an injection, gives them a prescription for a pill, I get paid. I get paid by Medicare, by Medicaid, by private insurance, by the Indian Health Service, because that doctor has provided an acceptable clinical service. If they go see one of my behavioral health providers who are licensed, clinicians based on the Western clinical modalities, I get paid. I do not and cannot get paid to provide access to traditional medicine, traditional practices, ceremonies. That's not billable under Medicaid. It's not billable under Medicare. Let me rephrase that. In the state of Montana, there are some states that are making a little bit of headway with their Medicaid coverage, Washington in particular. But here in the state of Montana, I cannot get paid, I cannot get reimbursed if I provide those services to my patients, to my community members, even though as American Indians we have generations of evidence showing the impact, the protective nature of these ceremonies, and that has really been what has motivated me to make this question, this research, this topic, the focus of both my doctoral research, but really basically my life's mission. That for the last 25 years, I've been so frustrated that I can't get reimbursed for those services, that I can't get folks, whether it's state officials, federal officials, market officials from private health insurance companies, to see these as valid services. I don't want that to be the case 25 years from now. And I really feel like it won't be. I really feel like things are changing. We're beginning to see a trend in the use of indigenous research methodologies and indigenous evaluation frameworks and research that is generating evidence that can withstand scrutiny, not beyond that of our elders. Our elders are very competent, very capable. If our elders say something works, I know it works. But we're beginning to generate evidence that holds up scrutiny beyond those elders. And what we're seeing is that evidence basically says exactly what our elders have been saying all along, is that the services that have been in place for generations, for millennia, are effective, they work, and they provide a protective factor for American Indians. And as community members, as patients, they need to have access to those services. So I was told by Peter that everybody in here has a background in Indian health. I'm kidding. So I'm assuming that there's going to be differing levels of knowledge, so we're just going to talk a little bit about some definitions and background. According to the United States Census Bureau, there are roughly 6 million American Indians, Alaska Natives, living in the United States. What does that mean? That means that there are literally 6 million definitions of American Indian identity. None of them are going to be exactly the same. So this is a question that I get asked a lot. What's the right term? What's the right phrase? I would advocate that really the best or the correct phrase would be to address people by their preferred tribal affiliations. So, that's not even always going to be in English. So yes, I'm Mandan and Arikara, but more than that, I'm Nueta and Sanish. And so for me, that would be the most appropriate. But again, I have 2 different tribes. I'm Mandan and Arikara. A lot of Native people throughout this country are members of several different tribes. So we can't, it would be very time consuming and difficult to actually try to come up with a term that encompassed every single identity that exists when it comes to American Indians. So I myself, throughout this evening, will probably jump back and forth between American Indian and Native American. I'm going to age myself a little bit. I grew up during AIM, American Indian Movement. So when I was growing up, American Indian was absolutely the term that was used. I think somewhere maybe around 90s, 2000s, it became more common to say Native American or Native. And honestly, I'll say Native, I'll say Indian, I'll say American Indian, I'll say Native American. So you're going to hear, for me, those terms are going to bounce around. And anytime when we're working with individuals, with patients, what we really ask is, what is your preferred identity? So if they want us, and I even do that, we're going to be having an event here on campus in March looking at contemporary Native health, and all of the speakers, I ask them what is their preferred tribal identity, tribal affiliation. I have 2 individuals on this panel from the same tribe, and they identify that affiliation differently. So one calls it the Blackfoot tribe, the other one, I'm not even going to try to pronounce it, uses the Blackfeet term for Blackfeet, and that's fine. So under one, I said Blackfoot Nation. Under the other, I use the identity that they select. So you're going to hear me jump around a lot between American Indian, Native American. Ceremony. There is only one type of ceremony. I'm kidding. Ceremonies are, again, as vast as American Indian identities. Different tribes had different ceremonies, and a particular tribe could have dozens or hundreds of ceremonies. So again, I can't say definitively what is ceremony. In my research, basically what I say is that it's time, place, and person dependent. So if the people who are there and are participating say it's a ceremony, I'm going to consider that a ceremony. It's not my place to tell a person from another tribe what is and is not a ceremony. If that's what their tribe recognizes as a ceremony, that's what their people go to as a ceremony, then that's a ceremony. I am going to go over some examples of common ceremonies that pop up in a lot of work that's done in healthcare, but this is not by any means meant to be all-inclusive. There are hundreds of different ceremonies throughout the United States. One thing that I wanted to talk about, this is not, now we're jumping into background rather than definition. For those of you who don't know this, practicing American Indian religions, culture, spirituality was against the law until 1978. The American Indian Freedom of Religion Act was passed in 1978. I was alive. So we like to talk about America as being, freedom of religion, the land of freedom, freedom of religion. But for American Indians, this country's first people, our rights to practice ceremony were not made legal until 1978. That's an important background as we're walking through this topic of why those ceremonies, that structure, those services that we had in our communities that provided us that protective nature, then were torn away from us largely, not entirely, but largely. And so what we're going to see is that that's really where the health crisis, today's health crisis, stem from, and bringing those ceremonies back to the people and to the community is the way that we can use our inherent community strengths in order to bring health back to our people. But just know that for American Indian, the trip, the venture when it comes to religion did not play out the same way that it did for any other American. And so as part of this, the Indian Healthcare Improvement Act, again passed in 1976 before it was even legal to practice American Indian spirituality and religion. But the Indian Healthcare Improvement Act is really going to set the stage for what we're going to talk about tonight. And another thing that I wanted to point out is that that was passed in 1976, which again, I won't say exactly when, but I was alive in 1976 for part of it, not for all of it. That is the first time in the history of the Indian Health Service, and on the next slide I'm going to give just a brief history of Indian Health Service, but that was the first time in the history of the Indian Health Service that IHS, Indian Health Service, IHS was authorized to do anything other than treat disease. That was the first time that they were authorized to do what's called health promotion, disease prevention. Up until 1976, and it's more, by that time it had been around for almost 150 years, more than 150 years, it was only authorized to treat disease. So again, what we're going to see is that this need for reinstitution of our ceremonies is addressing a systematic intergenerational deprivation that existed, and as American Indian people, we are putting back into place. And so the last thing that I want to talk about is, before we go on to the next slide as part of the background, is the Indian Health Service. And the Indian Health Service is the entity that is responsible for protecting and maintaining the health of American Indians living in the United States. It's a comprehensive system, meaning that it has hospitals, it has clinics, it has what's called health stations in rural areas. And as of right now, I didn't check actually lately, I should have, but last time I checked, there was 636 separate facilities that in 2018 provided services to more than 2.5 million people. So it's a large healthcare delivery system. It's a mega healthcare delivery system, which also is going to comprise some of the difficulties that we're talking about today. But it's a system that has been designed to meet the needs, ideally meet the needs of American Indians, regardless of where they live in the United States. That's because the federal trust responsibility to provide for the health of American Indians is not limited to reservation borders. That follows the American Indian wherever they're at in the United States. It's a federal responsibility. So because of that, the IHS system is structured into what we call 3 tiers. It's a 3-tiered system. So the I means that there are hospitals, health stations, health clinics that are operated directly by the Indian Health Service, the federal government. The federal government administers and manages those facilities. The T means that there are some facilities that are operated independently by tribes. Tribes have said, hey, we have the wherewithal, the ability, the capacity to run our own health program. We don't need the federal government in here. And it's a little bit more than that, because in the true, and after 25 years in this business, I'm going to sound really cynical, but in the true paternalistic style of IHS, you can't just say you have the capacity. You have to prove that you have the capacity by jumping through all these hoops. And once you do, you can take healthcare into your own hands as a tribe. And so, for example, in Montana, we have 2 tribes that have gone through this process. That's called compacting, or 638. And so Flathead and Rocky Boys have both compacted. So those tribes are actually in charge of how their healthcare delivery system runs, not the federal government. Any other Indian health program on a reservation in Montana is what's called a service unit. It's under the federal government. And then we have 5 urban Indian health programs in Montana. There are 41 urban Indian health programs nationally. And again, that's because the trust responsibility applies no matter where American Indians live in the United States. So there was, as part of the Indian Healthcare Improvement Act in 1976, it authorized the federal government to begin funding health programs located off of the reservations. And so in Montana, we have 5 urban Indian health programs. That being said, something that you can look at is that in fiscal year 2018, the budget of IHS was $5.5 billion. The budget for urban Indian health was $45 million nationally, less than 1%. The issue there is that 71% of American Indians live in urban areas. So we have less than 1% of the resources being strained to meet the healthcare needs of 70% of the population, roughly. Now, the answer there is not to take money away from the tribes. The federal government, especially for my first 20 years working in Indian healthcare, tried to set it up that way where they pit tribes against urbans. Well, if urbans want more money, then we need to take it from the tribes. No, absolutely not. Tribes are underfunded for their healthcare services. The 2018 estimations were that tribal programs are funded anywhere between 25 and 50% of need. So they're not even funded at 100% of need. Urban programs are funded at 13 to 18% of need. So it's not take from one to give to the other. It's that we need to find resources to make this system whole and make it work the way that it's designed to work. So I just wanted to give a little bit of background about Indian health so that, if you're not familiar with Indian Health Services, as I'm going through and talking about the different programs and what's going on, hopefully you have except I did want to say a little bit more right here, sorry. One of the things that I wanted to talk about was the history, briefly, of the Indian Health Service. In case you're not aware, the Indian Health Service did not start off as a benevolent service program. It started off in the War Department. So Indian Health was first started in the War Department in early 1800s. There's documents going back as far as 1802, 1803. And the purpose of the Indian Health, as it was originally established, was to contain epidemics to reservations so that American soldiers and American people who were living on or around reservation areas would not be contaminated. And the War Department especially didn't want soldiers, as they were moving across the United States, to come in contact with an epidemic and then bring that epidemic into the military. So the first doctors who were assigned to work with Indian communities were under the War Department, and again, the purpose was to contain epidemics. It stayed in the War Department for almost 50 years, and it was in 1842, I believe, that it finally moved over to the Department of Interior. The Department of Interior had it for about 30 years, and then they created this special, they also called it the Department of Medicine and Education, Indian Medicine and Education. That department lasted a whole, I think it was 4 years, 5 years, and then it jumped back to the Department of the Interior under the Bureau of Indian Affairs. And it stayed there, so that would have been, we're still in the 1800s. It stayed there until 1955. And in 1955, what we call the Transfer Act is when Indian Health Service was moved over to the Public Health Service. So, and was separated out from all other trust responsibilities. So the idea was that healthcare needs need to be addressed by healthcare professionals. Having somebody who specializes in building houses or roads is not going to help when we have healthcare needs. So the Indian Health Service was moved over to the Public Health Service in 1955, which is actually why it has that as part of its logo, and it has rested there ever since. And don't know exactly what the future looks like for that, but as far as right now, Indian Health does fall under the Public Health Service. The Surgeon General does not fall under the Bureau of Indian Affairs. So tonight I want to talk about ceremony, traditional Indian medicine, and I'm going to do my best to keep watch on time because this is a topic that I can talk about a lot. And really, what we're going to talk about tonight could be made into an entire course, but I'm going to try to get through as much of it as possible in about the next 35 minutes. I think 6:30. How long do I go to? 7:30. 7:30. Okay. But I want to have times for Q&A, so I'll try to get through it in 25 minutes.
Q&A is
after. Okay, great. So I wanted to talk a little bit about what ceremony and traditional Indian medicine looks like in Indian health today. health centers, clinics, hospitals that are working to address and meet the needs of American Indian people. What do ceremony and traditional Indian medicine look like in practice? So one of the most, I think, well-known types of American Indian ceremony is the sweat lodge. And so a sweat lodge is practiced in many different tribes, and this sweat lodge addresses all 4 aspects of healing. So here, this is, again, this medicine wheel is specific to a certain part of the nation. So even though you wouldn't historically and traditionally have found these in Alaska or Florida, I'm still going to talk about it using this model, mainly because it's a Plains model and that's where I'm from and that's how I was raised. So our 4 aspects, 4 facets of healing are physical, mental, emotional, and spiritual. And the sweat lodge is one ceremony that addresses all 4 of those components. And different tribes that do practice sweat lodge practice it differently. There are different rules and customs associated with the sweat lodge. I'll tell you guys a quick story. I'm from Missoula originally. The reason that I'm from Missoula is the tribe actually paid for my grandma to come to the University of Montana in the 60s and get her degree in nutrition. So when they moved over here, my mom was 10, and then she met my dad over here. They were a little too young. They were in high school at Sentinel when they had me, but that's okay. And so I was born right here in Missoula, but my mom and my mom's family are from Fort Berthold, North Dakota. So just across the border if you go into North Dakota. And so because of that, I was raised close enough that, I spent a lot of time over on our reservation, spent a lot of time with my family, spent a lot of time with, so again, different tribes use different terminology. The terminology where I'm from is root doctor. So we have root doctors, which, medicine man, different tribes have medicine men, some have medicine women, some have both. Our tribe has both. This one, we had a root doctor who worked with us, and I'm going to talk about him a little bit later. But so I grew up around my tribe and their practices, and then did my first semester here at the University of Montana, and found out that going to college in the same town with your friends was basically like high school without adult supervision, and it did not go very well. I got placed on academic probation and sat down, and my grandpa had a real solid heart-to-heart with me, and he said, maybe you need to put some distance between you and your friends. And so I was 18 years old when I left. I left Missoula. I went down first to Oregon, and then I went down and settled really in California. So my career in Indian health has been mostly in California. And so I worked for the tribes there for 6 years, and then I moved over to the urban side. And so the Native American Health Center, which we'll see some stuff from them later, they're actually the largest urban Indian health program in the United States, and they operate health centers in both Oakland and San Francisco, California. And so I got a job as a grant writer in their behavioral health department, and their behavioral health department was led by a non-native clinical psychologist, a white guy from a Jewish guy from Brooklyn, New York. Had the best accent ever. I used to love strangest ideas, weirdest ideas, but I loved listening to him talk because he's the best accent ever. But they had already a relationship established with a traditional practitioner, and I'm going to talk about that a little bit later. And so the traditional practitioner, in addition to offering sweats for the community, would do a sweat for the staff. And so I was new on staff. I'd only been, working at this place for I think maybe 3 weeks when this. He was actually housed in South Dakota, and we had the resources to bring him down to San Francisco once a quarter. And so he was coming down from South Dakota. It was, even though my mom's from North Dakota, families know each other. I'd heard the name, and never met him, never worked with him, but the director of the behavioral health program said, and he's going to lead a sweat for the staff. And I said, oh, well, like he's going to lead 2 different sweats? Or I'm not understanding, because there's staff who are men and staff who are women. And where I come from, those you don't sweat together. Men sweat with men, women sweat with women. And he's like, oh, no, we'll all go in there. And I was like, no, absolutely not. I don't know this guy. I don't know his medicine. That's not the way that I was raised. I am not comfortable with that. You cannot make me go into this sweat. And the director was like, oh, calm down. He's like, I'll tell you what. When Dickie gets here, so the practitioner's name is Richard Mooskamp, largely around South Dakota, North Dakota, known as Dickie. He's like, when Dickie gets here, talk to Dickie. He'll make you feel better. It'll all be okay. The next day, Richard was there, and I went to him, and I was like, Richard, hi, I'm DShane, by the way. Nice to meet you. I'm not okay with this. I was raised, I'm Mandan and Arikara, but raised mostly around Mandan ways, and I'm not comfortable going into a mixed sweat. I'm not comfortable going into a sweat. This is no disrespect to you, but with someone I don't know. And he said, absolutely. He said, you do not have to do anything that is not your way, that makes you uncomfortable. He's like, because that's not what this is about. Ceremonies are about healing. They're about bringing good medicine. If this is not your way, if this is not healthy and good for you, then you do not need to come in there. And then I went back and told Ethan that I didn't have to go, and he was kind of mad. But so Sweat Lodge, the whole point of that story is that Sweat Lodge looks different for every tribe. And when we get a little bit further down the line, I'm going to talk about the difficulty of one size fits all. So when we talk about ceremonies in healthcare today, the approach is going to be very complex, and it's going to be what I like to call a wicked problem. And so, in my master's program, we learned about wicked problems and the idea that, even when you try to come up with a solution, a lot of times that'll just raise more problems. And that's really what getting ceremony into contemporary healthcare settings is a wicked problem, in that it's not a one-size-fits-all easy solution. And we're going to talk a little bit more about that tonight. So in addition to Sweat Lodge, drumming can of its own be a ceremony in a couple different ways. Building a drum for some tribes is actually ceremonial, so they do that in a ceremonial way. And then how the drums are used are absolutely in ceremony. And drumming is, I expect and hope to do a lot more research on this, because I think it's one of the most misunderstood and undervalued components of healthcare for American Indians. And I'm biased because I grew up around a drum, but the fact of the matter is that drums serve as both prevention and treatment. They work on aspects of health that are both psychological and biophysical. I had to make a list of these so that I would remember, but emerging studies looking at the use of American Indian drums and drumming in healthcare has shown the following outcomes. And again, there's not a ton of research. This is emerging research. There isn't dozens of systematic reviews and meta-analyses out there. However, there are studies coming out. Studies are showing significant decreases in depression and anxiety, and a corresponding increase in psychological well-being, a significant shift away from a pro-inflammatory toward an anti-inflammatory immune profile. I am not a clinician, so I can't explain that in any more depth than I just did. And it's about to get even funnier having me say this stuff. I personally think this is my favorite. It leads to increased natural killer cell, and I practiced this word before I came in, lymphokine activated killer cell activity. I have no idea what those are, but it sounds really cool. Killer cells. And I also practiced this one, and I want to get it right. and increased dehydroepiandrosterone to cortisol ratios, or DHEA. DHEA, great. What's so big about that? Well, DHEA is associated with improved physical performance, enhanced libido, weight loss, bolstering the immune system, and slowing the aging process. Who doesn't want that? And all of those are results that are coming out of clinical studies looking at the effects of drumming. And so the idea is that this is a practice that many Indian communities have had in place for generations. And when we think about, well, how were they so healthy? How did they stay healthy? It's because we had these tools. We had tools for preventive care and treatment. And what we need to do is work on bringing those tools back into our healthcare delivery system. So as part of my research you're going to see at the end, I am conducting a systematic review and meta-analysis. I wanted to highlight one of the studies that's in there. And this was a clinical study, a clinical trial performed in Los Angeles called Drum-Assisted Recovery Therapy for Native Americans, or DARTNA. And so it got clinical trial approval from NIH. And this one focused on, when it says recovery, it was substance abuse recovery, both alcohol and other drugs. It was a small clinical trial, so there were only 10 participants. But even as a small trial, it did show some results. And so 8 of the 10 participants made it. You can see, I know this is too small to actually read, but the curriculum, here it says weeks 1 through 3, 4, it says, and so it ends up at 12. So it's a 12-week curriculum. 80% of the participants made it at least through the midway point, and then 50% of the participants made it through the entire 12 weeks participating. Of the participants who made it through, the 5 participants who made it through the entire 12 weeks, 4 reported absolutely no substance use at all. 1 reported drinking alcohol once during the 12 weeks. And then of the 3 who made it through the midpoint, 2 reported no substance use at all, and 1 reported alcohol relapse. So still a small trial, but still these were all people that came in with substance use histories. And so still some positive outcomes coming out of that study. And then ceremony, a lot of times we have ideas in our mind of what constitutes a ceremony. And like I mentioned, different tribes have different ceremonies, and tribes have many different ceremonies. And so one ceremony that I wanted to talk about was wiping of the tears, which is a ceremony that is practiced largely in the northern plains. So you would see it in a lot of the Lakota tribes, my tribe included. We are not Lakota, but we are what's called a Siouan tribe. So wiping of the tears is a ceremony that we use back on our reservation. Oh, and actually I was going to put in a picture of that for my family, and I forgot, but that's okay. But wiping of the tears is basically a pathway to catharsis. It is an opportunity for people to take that weight off of their shoulders that has been holding them down. Now that weight, it says wiping of the tears, so you might think that weight is always sadness. It's not true. That weight can be anything from depression, anxiety. It can be a physical illness. We're going to see on the next slide a young woman who went through this ceremony, and it was associated with physical illness, physical disability. And the idea is you're promoting that catharsis so that you can then begin a process of establishing healing, whatever that looks like for that person. It might look different for everybody. So this is a young woman, Sheila Jumping-Bull, who was actually, it talks about in here, no, I don't think it actually says the name, but she was a patient at the health center in Oakland where I worked, and this is published, so I'm not breaking HIPAA. She published this story herself. And so at that clinic, we actually brought down that same traditional practitioner I mentioned before, Richard Mooskamp, and he conducted a wiping of the tears. And as a young community member she had already undergone several tragedies, things like losing family members, very close family members, losing a romantic partner to gang violence. So she already had those tragedies, and then because Oakland is rife with violence, and so a lot of our urban American Indians in Oakland, violence is an everyday issue that they're confronting and dealing with. But then she actually was the victim of a stray bullet that physically incapacitated her. And at the time this happened, the community, we came together, supported her. She was told by the doctors that there was a large possibility that she would never walk again. Even if she did walk again, it wouldn't be without assistance. She would need a cane or something. And so that was really weighing heavy on her. She was a mother. She's like, how am I going to provide for my children? So when Richard came down, several of the, what we call aunties in the community really encouraged her to come participate in this ceremony. So she had never gone through a wiping of the tears ceremony, I don't think. She didn't really know what to expect. And when you hold the wiping of a tears ceremony, it's done usually for a particular person facing a particular loss or issue, unfortunately down there, because the community in San Francisco is so physically removed from access to the traditional practitioner, we kind of have to stack those ceremonies back to back. But everybody came together to participate in this ceremony for her, and she'll go on and tell everyone that she meets now how that ceremony changed her life, how it providing that catharsis, that ability to let go of the anger and the fright, the scaredness, how she was going to provide for her family, all of that, those heavy things that she was feeling, having that lifted then led to an opportunity for her to focus on physical healing, and to the point where today she walks mainly unassisted. She does still have a cane that she has to use sometimes, but she can absolutely walk unassisted, which the doctors were very skeptical about after her accident first happened. And and I'll talk a little bit, about, I said where I come from. Wiping of the tears is a ceremony that we do. I've been through a couple of those ceremonies now, but one I'll talk about, as a child, it's very common for American Indian children to suffer physical abuse, sexual abuse, emotional abuse. And so as a child, I had that happen to me where my brother and I were molested, sexually abused by a man who had access and was believed by our family to, be a friend who was not. And, that happened when I was very young. He was caught by the time I was 8. He was in jail by the time I was 9. By the time I hit, and I'll be honest, I really spent a lot of my childhood just completely having it blocked out. Didn't even think about it. And something happened. I cannot to this day tell you what happened, but something happened when I was 19, and this switch went off, and I was just filled with rage, anger all the time, over anything, everything. I was just always mad, and I had gone through that for about 2 years, and my family, said, well, they brought in, and my anger was also very much inward aimed, and so I ended up with ulcerative colitis, was in the hospital dealing with a lot of stuff, and that's when my family said, it's time to call Uncle Willis. And so he's a root doctor. He's not my actual uncle. Uncle is a title that's given, and so Uncle Willis is a root doctor. Put me through the ceremony, doctored me, did the wiping of the tears. I was back home, Fort Berthold, for several weeks, and was able to, through that ceremony, get to a place of health that Western counseling had never been able to provide for me. My parents forced me to go to therapy when I was in middle school. My high school counselor, basically forced therapy on me. And might work for some people, and that's great. But for me, what worked was having access to those ceremonies and the traditional practitioner. Now, I had that because my family could make that happen. That's not the same for every American Indian person. And so those are some examples of ceremonies and how what they look like today in modern practice. But I also want to talk about what does Indian medicine actually look like in a clinical setting. So when I talked about, so for her wiping of the tears, that was actually performed at the clinic. So in Oakland, we actually built a brand new clinic from the ground up. It was a $27 million project, and as part of that, we actually put in a ceremonial space. So we could hold the ceremonies right there at the clinic. For me, when I was going through mine, I went back to the reservation. And then Dartna, theirs was actually done at a community center. That is a healthcare setting, and that is a healthcare setting. So we can see that these ceremonies do absolutely take place in healthcare settings, but now what I want to talk about is really how do we structure that. I talked about, when I first got into this business, Indian Health Service would be the last one who would pay for traditional services. Even though nobody would pay, it's not fair because nobody would pay. But the fact of the matter is, Indian Health Service, who, in my opinion, should have been the agency that understood our need for these services and supported our need for these services, would not, in any way, shape, or form, endorse or reimburse these services. What a change in 20 years, 25 years, where now the Indian Health Service is actually allowing the hiring of traditional healers at an IHS service unit. So this is for Fort Belknap, which is a federal service unit. So this is the federal government that's operating this program and hiring for a traditional healer counselor. So I just wanted to pull up, you can see some of the duties that they have, traditional counseling. So in our program here at Missoula Urban Indian Health Center, it's what we call spiritual counseling. And so the traditional practitioners offer spiritual counseling from a tribal cultural perspective. They talk about health maintenance, healthy lifestyles. They also do absolutely perform healings and ceremonies, whatever that might look like for that practitioner and that person. And so, I'm going to talk about how difficult it is to get that to line up, the practitioner and the person, but I'm going to talk about it on the next slide. And so they actually, IHS allows this practitioner to provide what they consider diagnostic services. 10 years ago, if you'd ever heard the word diagnostic after the word traditional, you would have been thrown out the door of any federal government office. And now what we have is a traditional practitioner who is actually in their job description is to provide diagnostic procedures and ritual treatment. And then also, a very important part is providing training to the other folks who work in that health system as far as how to integrate cultural and traditional services into that healthcare system. So that is a position, I know it says no longer being accepted. I think they did actually hire somebody for that, but that was just posted a couple months ago. So that's a new position at Fort Belknap. Which also I want to really quick add, Fort Belknap, for those of you who may not know, at almost exactly the same time went through a suicide epidemic and lost several community members, but especially several youth to suicide. And so having this person come on at this time is so symbolic in an effort to bring back those protective factors that I was talking about that are inherent in our culture, our medicines, our traditions, and bring those back to the community to combat that kind of epidemic. And so Seattle Indian Health Board, I think, is one of the best examples of how traditional Indian medicine can play out in a modern environment today. And so they actually have a traditional Indian medicine department. 9 to 5, basically. 9 to 5, Monday through Friday. Oh no, 10 to 5 on Tuesdays. I'm assuming admin meetings. Just like any other department. Medical, dental, behavioral health. Traditional Indian medicine is a department that operates within that organization. In their electronic health record system, they are set up as a department that can make referrals and receive referrals. The providers are set up as providers in their healthcare system, so that if the traditional practitioner is working with somebody, and as part of this, they're disclosing that, they're dealing with some kind of pain, et cetera, and the traditional practitioner believes that, okay, well, this is something that you should also talk to a clinician about, a behavioral health specialist. The traditional practitioner can make that referral, just like any other provider. And so that system is set up. This, though, highlights the challenge, so I'm going to talk about it on this page and the next page. Seattle is absolutely an urban multi-tribal environment. The Seattle Indian Health Board largely designs their services around the coastal traditions. And so the providers that they have there are, and I'm probably going to say this wrong, but Duwamish. And so those are the traditional medicine providers at that clinic. So they're going to be providing those services from that tribal perspective. Now, that being said, there are a lot of people who might be from another tribe or not be native at all who appreciate that and want those services. And so that is absolutely amazing and great that we are providing those services. However, it's important to note that it is a limitation. So if you have someone like me, like I mentioned before, if I'm going to go into a sweat, a ceremony, etc., I already have preconceived ways that has to go. And so it's not that I don't like Duwamish people, I don't want to work with the Duwamish people. It's that I'm not going to get the same effect from that interaction as I would if I were working from a practitioner who is more familiar with my tribe and my background. And so that's something that we run into in healthcare for American Indians. It's a little bit easier on the reservation-based systems because usually you're dealing with a tribe or a few specific tribes. So for example, where my tribe is Mandan and Arikara, but it's part of the Mandan Hidatsa Arikara Nation. So you have 3 tribes on one reservation. But still, that means that any services on our reservation really just have to be tailored around those 3 tribes. So you have to have somebody, this is how it plays out when you look at the tribal education, tribal health, tribal anything, language. You got your Mandans, your Hidatsas, your Arikaras, and they're there. So they do that. That's much more challenging when you're talking about an urban environment. Even when we just talk about Missoula. Missoula is not Seattle when it comes to population. In 2019, so I just got our 2019 numbers, at Missoula Urban Indian Health Center, we saw people from 68 different tribal backgrounds. I can't afford 68 full-time traditional practitioners. So then the issue becomes, how do we make this work in a system and a setting that is multi-tribal and intertribal? And so one example of how that is happening, it's definitely not perfect, but how it's happening is the Native American Health Center of Oakland, San Francisco. And so they have contracts, again, because they have the resources, largest urban Indian health program in the country. So they contract with traditional practitioners from several different tribes, sort of, I would say, strategically located throughout the United States. So you've got Richard Moves Camp, who's Lakota from South Dakota, Mona Stonefish, who's Anishinaabe, Steve Darden, who's Dene or Navajo, Martin Martinez, who is Pomo and Wapo, and those are sort of their core traditional practitioners. And then as needed, as available, they'll work with other traditional practitioners also. But they have this core so that, yes, even though living in Oakland, I might not be able to, just hop in the car and go see Uncle Willis, at least I know that, once every 3 months, Richard's down there. I never did attend any of his sweats because they're done differently, but I did attend several other ceremonies. The wiping of the tears, pipe ceremony. The pipe ceremony is very similar between our tribes. So I was comfortable enough attending several of the ceremonies that at least I got access to that to an extent. And so the idea is, how can we try to let people have access to those services as much as possible? So in Oakland, they have these different providers. And so there's, unlike Seattle, which was a department with full-time providers, they contract with different providers and they bring them down to do different activities. So here, I know you can't read this, but the drum circle was actually started by Richard. Mona did the talking circle. Talking circle, absolutely a ceremony. A lot of people, I think, have maybe not a clear picture of what a talking circle is. That it's a word that gets thrown around. It gets thrown around in business. Let's have a talking circle. Let's have a powwow. Well, no, those are actual talking circles, a ceremony. A powwow is a social ceremony. And so talking circles, Mona does them from the Anishinaabe perspective. And then I would be remiss if I talked about traditional Indian medicine and didn't actually talk about the medicines, the physical medicines themselves. Here on campus we have Dr. Rosalind Lapierre, an expert in traditional medicines here in Montana. But many tribes have medicines that they incorporate into their healing. And so in San Francisco, we would actually go out and with our patients and community members do a trip to pick cedar, pick sage, and then bring them back to the clinic and teach them how to wrap it traditionally, how to care for it. And then they have those medicines to use on their own at home or with their families. And so getting those actual medicines, cedar, sage, tobacco, where I'm from, bear's root, kinnikinnick, all of these medicines that our people are used to working with, making sure that they have access and teaching. Because the fact of the matter is, especially in the urban areas, if you're 2 or 3 generations removed from anyone who knows how to use those medicines, you're going to need instruction in how to use those medicines, how to incorporate them into your healthcare. I'm lucky enough that I'm of the generation where, for my tribe in particular, sweetgrass is considered a woman's medicine. Sage is a man's medicine. With gray sage or white sage, I can do pretty much anything that I need to do on my own. And it's just like in modern healthcare. So a lot of times if people see, oh, you know how to use sage, are you a medicine man? I know how to use Advil. I know how to use Dayquil, NyQuil. No, I've been taught by my family how to use these things. Yes, there absolutely are practices that root doctors perform, medicines that they would know how to use in ways that I would have no idea, just like I go to the doctor when Advil or Dayquil or NyQuil doesn't cut it. But I absolutely have in my arsenal of medicines that I can use. Next to the ibuprofen is the sage. And having those helps keep my health and well-being in check and in perspective, in balance. And that's what we need to make sure that our patients and our community members have access to as we move forward. It is definitely not about moving away from clinical care. It's about incorporating generations old medicine into the care that we receive right now. So I'm running up on time, and pretty good timing because this is my last slide. But forthcoming, so this is really where my interest in research lies. Is I don't need to see a published article to know that wiping of the tears has an effect. I know because I went through it. I know because I've seen other people go through it. I know that these ceremonies are effective. I know that they work. That being said, I want to be able to bring those services into my clinic and clinics around the country. And in order to do that, other people need to know that these things are effective. And so the forthcoming systematic review and meta-analysis that I'm working on is looking specifically at quantitative efficacy data that looks at ceremony and other traditional practices, because again, it's very hard to nail down a different definition of ceremony. You know, the idea of building a drum, using a drum, may be considered ceremony by some, may not by others. So use this catch-all of other traditional practices. And then I'm looking specifically at substance abuse. You know, the work that I do in Indian health over the last 25 years, I can't deny the impact and the role that substance abuse has on the health of my community. And so that's where I'm focusing my efforts. You know, I went through a review that, you know, for anyone who's done systematic reviews, this is, you know, 4,688, sounds like a lot, but, you know, most of those had nothing to do with it. So I had to just spend, and my partner Jason is here and had to watch me literally spend hours reading. I'm like, nope. It was tedious and it was horrible, but it's okay because it got me down to here. And so going through this process, the Prisma process, ending up with 7 articles that do have quantitative data associated with the use of ceremonies and other traditional practices to address substance use. And so I've ended up with 7, and all 7 of those articles show at least moderate evidence supporting what we as Indian people already know, is that our ceremonies work. They make people healthy, they keep people healthy, and my hope is that by bringing these back into the clinical environment, we can do an even better job at keeping our people healthy and reducing disparities for the next generation. So thank you very much, and happy to do questions and answers.
So do urban Indians, do they go to the clinics, other clinics, or do they just go to like the Indian Urban Health Clinic to get services?
That is absolutely up to the individual person. So they do not have to come to our clinic. Obviously we want them to come to our clinic, but if they have private insurance or no insurance and they want to go to, you know, here in Missoula, we have Partnership Health Center, which is a community health center. So if they want to go to Partnership, if they have private insurance and want to go to a private doctor, they absolutely can. And the same, you know, just to, I think there's a lot of misconceptions about Indian health in general, but one of the things is that you don't have to be native to come to my clinic. You have to be native for me to use Indian health service funding to provide you with services. But if you have Medicare, Medicaid, private insurance, you can come in. A shot is a shot. I will give you a shot no matter what color, age, gender. You could be an alien from Mars, and I hope you have Medicaid because we will take you. So, but it's a great question. So no, Indians absolutely have the option to choose wherever they want to go for care. So the idea is that by bringing ceremony and traditional services into our clinic, that is how we are going to better and best serve their needs.
How do you respond to the controversy about I'm 50% Indian, I'm 25% Salish, and do you have any guidelines in terms of eligibility, I guess?
So, like I mentioned, there are guidelines imposed on us by the Indian Health Service if we're going to use IHS funding. And that is that you have to be an enrolled member of a federally recognized tribe or a first or second generation descendant. Now that is for us to use IHS funding. IHS is not my only funding source. So we provide services to everybody, and again, they don't even have to be native, but if they are native, I don't impose the same eligibility definition on them that IHS does. Now, if you go to a service unit, so we're talking about Browning, you absolutely have to meet the federal definition of Indian to get services there. If you go to a tribal program like Flathead, you have to meet their definition, whatever it is. And so our definition at Missoula Urban Indian Health Center is we want to help anyone and everyone who has need of our services.
Increased demand of using ceremony and drumming and all that, do you foresee a shortage medicine then, like with doctors?
I would say that, especially in urban settings, there already is a shortage. Like here in Missoula, it is very difficult for me to implement this program because I don't have a lot of funding. So when for those of you that are here, when I talked about the funding structure, urban Indian health, less than 1% of the total IHS budget. To put that in perspective, my annual funding contract from the Indian Health Service is $618,000. The annual funding contract for Flathead is $26 million. That's not the same. So with my $600,000, I have to try to make that go as far as I can. Now, the way I do that is by not having IHS be my only funder. So I try to get in other funding. But the fact of the matter is, there are not going to be necessarily a medicine person from all 7, well now 8 federally recognized tribes in Montana living in Missoula. So I can't hire them full time, and if I'm going to contract with them to come in and do services, I have to pay for travel, per diem, lodging, all of those expenses. So right now, providing those services is actually very expensive, which again is why my work is to make the argument to have Medicaid, Medicare, Indian Health Service, other insurances help offset that cost so that I can offer those services. Now, once the money's in place, then we might have a shortage of medicine people because they all have jobs, which would be great.
So, talking about medicine people, have you read any instances of how providers have addressed, I guess, credentialing?
Yeah, and that's, so I mentioned at the beginning of the talk that this could literally be a full course, semester-long course. So there's 2 issues there. One is, how do we do credentialing in a way that is culturally appropriate? It's not going to look necessarily the same way. So at my clinic, I do credentialing, which means when I have a doctor come in, I need to see a copy of their license, I need to see a copy of their diploma from wherever they got their medical school degree, etc. I need to have all that on file. That's not going to look the same for a traditional healer. Now, some tribes are actually putting that together. They're doing training programs. They're actually providing documentation. And so the Seattle Indian Health Board is working with the Duwamish tribe, and they are actually doing a training program. And so then you're certified as a traditional healer under that particular approach and custom. So one issue is, yes, how is that going to look in a way that is culturally appropriate? There's another side to that coin, though. And something that I saw a lot in San Francisco is then we also end up with opportunities for spiritual abuse. And so we have people who bring in, somebody says that they're a medicine person, a healer, a person of that kind of stature. They end up somewhere 1,000 miles away and begin, providing services really by preying on people in that community. And so how do we make sure that that doesn't happen? So there's both sides of that. How can we do credentialing in a way that actually makes sense, but how can we still make sure that people are not being in a position where they could get hurt? And I don't have a great answer. I do know that there are tribes that are beginning to put that kind of stuff into practice, and it'll be really interesting over the next 20 years to see where we end up, so that 20 years from now, there really might be sort of a certificate or a degree that could be associated with that, so that folks know who they can go to for legitimate services.
So you ever read like how Seattle does theirs, or?
Seattle started their own program, and so they did it in partnership with the Duwamish tribe. So in order for someone to be a traditional Indian medicine provider there, they have to go through their training program, and it's done from the Duwamish perspective. And that's great. That's one way, and that'll work for them. That's not necessarily going to work everywhere, but at least it's a start. It's more than what was in place 10 years ago. And sorry, I saw a couple other hands. Peter.
I'd like to follow up a little bit on your meta-analysis. I don't know how far you've gotten with that yet, but the question is do you think, or is there any evidence that you talk about the moderate evidence supporting protective nature. Does that vary from different ceremonies and different traditional practices is my question. I mean, maybe some work and some don't.
That is absolutely possible. In the 7 articles that we ended up with, there is actually a variation of ceremony. So one of the articles, they're looking at ayahuasca, which is a South American tradition, but it was brought up, a tribe, I'm going to get the state wrong. I'm going to say Wisconsin, but I could be wrong. It could be a flyover state, which I'm in Montana. I really shouldn't judge, but anyway. So one of those Midwest states. And so the tribe actually brought a practitioner up from Peru to work with their tribal members. And so that was a ceremony from South America implemented in a North American tribe. The Dartna is drumming that was just done as a drumming circle. Oh, and that's the other thing, is that several of the articles actually are cross-sectional surveys. So the ceremony is defined by whoever's taking the survey. So it doesn't say, have you participated in a sweat lodge? It says, have you participated in a ceremony? So, it's great that, yes, there is some moderate evidence, and the 7 studies that ended up making it all the way through range from fair to good. There's no excellent, methodologically sound studies, but still, right now we're working with no meta-analyses on ceremony, so at least this is a step forward. And so it will be interesting as this field grows, if we do see that, yes, there absolutely might be some, but what we also have to consider is that these communities have been using these ceremonies for generations. So if they weren't effective, they probably would have stopped using them long ago. And then I thought I saw some hands.
Maybe one more question?
Uh-oh, now that's a lot of pressure.
Okay, so you talk about how this is a public health issue, and as a healthcare professional student, like when I get out into the profession, how can I educate my fellow coworkers about this issue?
Well, so in the 25 years that I've been doing this, the question that I get asked the most is, why is there Indian Health Service? Why not the other day, it was several months ago, it was last year sometime, Missoula hosted the National Conference of State Legislatures. We had, and they asked if they could have a tour of our clinic. So I had legislators here from all over the United States, and I got that question several times. And one of the guys, he was from Arkansas, and what he said was, just in driving from the hotel to your clinic, I passed by a hospital and several doctor's offices. Why do we need Missoula Urban Indian Health Center? Why aren't those hospitals and doctor's offices good enough? And the answer is that what we are seeing more and more evidence to back up the notion that when healthcare is delivered in a way that is culturally tailored. I focus my evidence on American Indians. This is probably true for any culture out there. But when it's delivered in a way that is culturally tailored, it is more effective and more efficient, especially cost efficient. And so I'm going to take just a minute to say what that means. So what we see at Missoula Urban Indian Health Center a few years ago, we didn't have a diabetes prevention program. So what we did was we referred out to the diabetes prevention program at St. Pat's. I'm on the board at St. Pat's. I love St. Pat's. This is absolutely nothing against St. Pat's. But what we saw was that for our community was an utter failure. Almost none of our people even completed the diabetes prevention programming. And those who did not show any spectacular outcomes. And then we took the program in-house and culturally adapted it so that now our diabetes prevention program includes berry picking, where we teach them where to find berries, how those berries were traditionally gathered, stories about the berries. We do a buffalo hunt, a bison hunt up on the Flathead Reservation. We teach them how to cook traditional meals. So what did, we largely focus on the tribes over here, so Salish, Kootenai, Penderay, Blackfeet, Confederacy, you know, what were some traditional foods there, teach them how to cook those, and do the language, the culture, the tradition, and then what we see is that they begin to internalize that, make those foods at home, and that's when we start to see changes in their healthcare. So the hundreds of dollars that went into their time at St. Pat's was not as effective as the money that went into their time at Missoula Urban Indian Health Center. And the last thing on that is that American Indians, because of the history of the nation's relationship with the United States, a lot of times will not go to hospitals, will not go to mainstream healthcare providers. Then what happens is they end up in the emergency room. And what is ending up as being thousands or tens of thousands of dollars could have been prevented with a $173 visit to my clinic. And so there's a cost argument and an effectiveness argument.
I think that's a great place to conclude what was a wonderful and enlightening lecture. So please join me in thanking you. So next week, actually we're kind of continuing this discussion a little in the same vein, a little bit, but it's a little bit different. We're going to have a talk by Ryan Tolson-Mee, and he's going to talk about technology's growing impact on traditional health systems. So you may see some continuity there, and a whole different perspective, of course, but some interesting ways to compare things across the board. So see you here next week, same time, for Ryan Tolson-Mee's discussion.